Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm doing another Kahoot, and I'm going to be going over Myasthenia Gravis and Parkinson's disease. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it. Press that like button now so you don't forget. Subscribe to this channel if you haven't done so already, and press that red notification bell so you'll be notified every single time a new video is released. Please don't forget, I'm now offering next generation NCLEX reviews as well as one-on-one tutoring sessions or consultation sessions. You can reserve your spot right now by going to my website, nexusnursinginstitute.com. And while you're there, be sure to check out the audio lessons that I also have available. Also, almost daily, you can find me covering a variety of nursing topics on my other social media platforms, such as TikTok, Instagram, and Facebook. So be sure to check me out there. All right, guys, without any further ado, let's get started. Myasthenia crisis and Parkinson's disease. Okay, so which is an incorrect statement regarding myasthenia gravis? Which one is incorrect? Is it an autoimmune disorder? Acetylcholine receptor antibodies interfere with neuronal transmission. The transmission of impulses to voluntary muscles are affected, or it's a demyelinating disease resulting in the destruction of CNS myelin. Which one is incorrect in regards to myasthenia gravis? What do you say? Okay, guys, so the correct answer, or I should say incorrect, because we're looking for the incorrect answer choice, and it's the green one that says this is a demyelinating disease resulting in the destruction of CNS myelin. When we're talking about the destruction of CNS myelin, this is an autoimmune disorder, but it's not myasthenia gravis. That is multiple sclerosis. Okay, all of the other answer choices are correct in regards to myasthenia gravis. So when we're talking about myasthenia gravis, it is an autoimmune disorder. It is when the acetylcholine receptor antibodies interfere with the transmission of impulses, and it does affect the voluntary muscles, right? But it has nothing to do with destruction of the myelin sheath. When we're talking about destruction of myelin sheath, that is multiple sclerosis, not myasthenia gravis. Okay, you guys are asking me to zoom in on the live. Okay, give me 1 second. That's the best I can do, guys. Next question. This is a select all that applies. What possible clinical manifestations would you expect to see in a patient that has myasthenia gravis? Here are your choices: diplopia, ptosis, difficulty speaking, choking or aspiration, respiratory failure, bowel and bladder incontinence. Now, remember, we're talking about myasthenia gravis, and this is a select all that applies. How do you treat select all that applies? You treat them as true or false. Don't try to clump them together for it to make sense. Individually, look at these signs and symptoms and choose the answer choices that you think applies to myasthenia gravis. Okay, so let's talk about this. With myasthenia gravis, you're going to see severe muscle weakness. Patient can have double vision, ptosis. They can have difficulty speaking, and that can even cause them to have choking or aspiration. That the muscle weakness, remember, you even use respiratory muscles, right? Those muscles can be so weak that the patient can't breathe and the patient has to be placed on a ventilator. Absolutely, they can go into respiratory failure and have bowel or bladder incontinence. Think about it. There's muscles that are causing peristalsis for their bowels to move, right? There's muscles of the bladder that has to contract for the patient to be able to urinate and expel the urine appropriately. So all of these are clinical manifestations that you may see in a patient that has myasthenia gravis. True or false? Myasthenia crisis or myasthenic crisis is attributed to overstimulation of anticholinesterase agents. Is that true or is it false? It's false. Most of you guys chose true, but it's false. And so let me tell you something. Here's the way that you remember it. If the patient has myasthenia gravis, right, they've got extreme weakness of the muscles. If they get too much of the anticholinesterase agents, that's going to cause cholinergic crisis. If they don't get enough, that means they get an under medication. That doesn't make any sense. They get a subtherapeutic level of that medication that causes myasthenic crisis. So when you see myasthenic crisis, think of myasthenia gravis, except 1,000 times worse, right? So if the patient is under medicated, they don't get enough of the medication, they can get myasthenic crisis. So it's not over medication, it's under medication. When they get too much of the medication, it doesn't cause a myasthenic crisis, it causes cholinergic crisis. This is very important. You need to know the difference. If you guys have a test coming up, make sure you write this down, because I guarantee you that will be one of the questions that you're going to see. Over medication, cholinergic crisis; under medication, myasthenic crisis, okay? What's the name of the condition that's associated with over medication of anticholinesterase agents? And I just gave you guys the answer. What is the answer? Is it cholinergic crisis? Is it hypertensive crisis? Is it thyroid storm or myasthenic storm? If you weren't able to enter the room, guys, just put your answer in on the live. Very good. Cholinergic crisis. So when the patient's over medicated with the anticholinesterase agents, you expect to see those signs and symptoms of cholinergic crisis. All right. Hypertensive crisis, that's when their blood pressure through the roof, right? They might they might have seizures, they might have other clinical manifestations. Thyroid storm, that's when the patient's T3, T4 is way high. They have hyperthyroidism times 1,000, right? And myasthenic storm, I just made that up. That's not a real condition, right? The patient can have myasthenic crisis where they have a subtherapeutic level, but not myasthenic storm. So anyway, when the patient is over medicated with anticholinesterase agents, we call that cholinergic crisis. That's what it can cause. Select all that applies. All right, what are the signs and symptoms of cholinergic crisis? Select all that applies. So think about the signs and symptoms you expect to see in the patient that is over medicated with those anticholinesterase agents. What types of signs and symptoms would you expect to see? Here are your choices. Diaphoresis, where they're sweating all over the place. Diarrhea, muscle twitching. On other exams, you may see the word, I can't pronounce, but it's something like facilitation. It starts with an F. Anyway, that means muscle twitching. Muscle cramps, increased double vision, increased diplopia, or increased ptosis, which is the drooping of the eyelids. What are the clinical manifestations you expect to see with cholinergic crisis? How do we pronounce that word? Felicitations? Oh gosh. Facilitations starts with an F. All right, so the signs and symptoms of cholinergic crisis: patient is over medicated with the anticholinesterase agents. We expect to see diaphoresis, the sweating all over the place, diarrhea, that muscle twitching, muscle cramps. Two signs and symptoms we don't expect to see is increased diplopia and increased ptosis. I want you to think about it. Diplopia, that double vision; ptosis, the drooping of the eyelids. We see that in what? Myasthenia gravis, right? We see that in that extreme muscle weakness. So if the patient is getting too much of the medication for that, We're not going to see that weakness. If anything, we're going to see it overcompensate. We're going to see that muscle excitability. We're going to see the contractions, such as the muscle twitching and the cramps. So the last two, increased diplopia, increased ptosis, what do we see that in? We see that in myasthenic crisis. Okay, not cholinergic crisis, myasthenic. If your patient's hospitalized for myasthenia gravis, what should be available at the bedside? What do you think should be available? The patient's in myasthenia gravis. Should be benzodiazepine, should be an NSAID, should be a loop diuretic, or should it be a tracheostomy kit? What do you think should be available at the bedside? Thank you, honey. Okay, guys, and the correct answer is the tracheostomy kits. Think about it. I just said to you guys that the patient with myasthenia gravis has extreme muscle weakness. It takes respiratory muscles in order to even breathe, right? So that weakness can be so bad that they go into respiratory failure. They might even have to be placed at a vent. You need to have a trach kit right there at the bedside just in case. What's the treatment for myasthenia gravis? Would it be atropine sulfate, levodopa, iron, or pyridostigmine bromide? What do you think? Don't give up on the live, guys. Keep typing in your answers. Okay, very good. Pyridostigmine bromide. That is a treatment you expect to give for myasthenia gravis. Now, here's the thing. Let's say you kind of over-treat the patient, right? What is the antidote? What would you give if they get too much of that pyridostigmine bromide? And the correct answer is atropine sulfate, which, by the way, is an anticholinergic. But atropine sulfate is what you're going to give if you accidentally give too much. Patient has too much in their system. Now, the other choice is levodopa. That's a dopamine agonist. And iron, you guys know what iron is. Iron is important for the production of hemoglobin. And remember, hemoglobin, that's what carries oxygen in the blood. The patient with myasthenia gravis should plan activities for when? Should it be early in the morning, early in the afternoon, early in the evening, or late evening? When should the patient with myasthenia gravis plan activities? You guys are doing great on the live. Everyone's answering correctly. Okay, correct answer, early in the morning. Think about it. Myasthenia gravis, severe muscle weakness. The patient's weak. So early in the morning, right after they've gotten 8 hours of rest, when they have the most energy, that's when they should plan activities. Let's talk about Parkinson's disease. So Parkinson's disease, this is a disease that's caused by a deficiency of what? Would it be serotonin? Would it be epinephrine? Would it be dopamine? Or would it be vitamin C? Very good, dopamine. That is the problem, the major problem in Parkinson's, deficiency of dopamine. Now, our other choice is serotonin. I talk about this all the time. Serotonin is our feel-good neurotransmitter, right? Patients got depression. The first choice you expect to see ordered for that patient with depression is an SSRI. Epinephrine, that's your fight or flight, right? And then vitamin C, you guys know vitamin C, ascorbic acid, is good for what? Healing. Okay. Select all that applies. What are the signs and symptoms of Parkinson's disease? Here are your choices, guys, and you're going to have more than one answer choice, or you may have more than one answer choice. Signs and symptoms of Parkinson's disease: tremors at rest, rigidity, bradykinesia, postural instability, drooling, shuffling gait. What do you expect to see in that patient with Parkinson's disease? Select all that applies. Thank you for liking the live, guys. I see them. Thank you. I see all the hearts. All of them. So we know that Parkinson's patient doesn't have enough levodopa, and what you see are TRAP symptoms. TRAP, tremors at rest. So even when the hand's at rest, you'll see the hand doing this. Take a look at my hand, guys, just like this, right? R, rigidity, right? When you're walking, your hands are supposed to swing by your side, and that kind of helps with your equilibrium. It helps with your balance. The patient with Parkinson's, they're very rigid. They're very rigid. It's like they're walking like a robot. Bradykinesia, their movement, kinesia, the movement, Brady, slow. They have slow movement. Matter of fact, one of the things you have to teach a patient with Parkinson's disease is to pretend that every step in front of them has a line, and they have to step over that line. So they have to physically lift their leg and step over that line, because the patient is moved slowly. There's not fluidity in their movement, and they have a shuffling gait, so that puts them at risk for falls. They have postural instability. Why? Because instead of keeping their head up high, they tend to be, the shoulders tend to kind of stoop, and they're looking down. Let me ask you something. When you're looking at a race, do you ever see anybody looking down? No, because the minute you look down, you kind of lose your equilibrium. You have to look up, and the patient with Parkinson's has that shuffling gait, and they're usually looking down, and kind of messes with their balance. So they have postural instability. Drooling, absolutely. They have drooling, and that puts them at risk for what? Choking, aspiration, and the shuffling gait, as I mentioned already. You see one thing I don't have on here that I do want to mention. What do you call it? Look at my fingers. I forget what you call it, but the patient tends to, their fingers do like this. It's called, guys on the live, what's it called? I can't think of it. When their fingers do that. Thank you. Pill rolling. Thank you so much. So you see how my fingers are going like this? This is called pill rolling. And you tend to see their fingers move like that. That's called pill rolling. For test taking purposes, that's one of the questions they like to ask a lot as well. So make sure you know it. Select all that applies. Which drugs are part of the expected treatment plan for a patient that has Parkinson's disease? Again, guys, this is a select all that applies, so there may be more than one answer. Your patient's got Parkinson's disease. Which medications do you expect to be ordered as part of their treatment plan? Here are your choices: morphine, chemotherapeutic agents, anticholinergics, dopamine agonists, MAOIs, and COMTIs. What do you guys think? Okay. For Parkinson's disease, you expect to see anticholinergics ordered, such as atropine. And that anticholinergic, that's actually for those secondary symptoms that you see with Parkinson's disease. Dopamine agonists, such as levodopa, that's the primary medication you expect to see ordered. MAOIs. Now, the MAOIs, actually the MAOIs and the COMTIs, those two medications, you expect those to be ordered when The dopamine agonists such as levodopa and the anticholinergics don't work. When they don't work, that's when you'll see the MAOIs and the COMTIs added to the anticholinergics and the dopamine agonists, okay? Which drug is used to treat secondary cholinergic symptoms such as drooling, sweating, and tremors? I'm sorry, I gave you the answer already. So what is it? Is it levodopa, atropine, selegiline, or entacapine? I spelled that wrong, but it's entacapine. Which medication do you expect to be given for those secondary cholinergic symptoms such as drooling, sweating, and tremors? Very good. Atropine. I just gave you guys the answer. I told you anticholinergics. Atropine is an anticholinergic. Please do not forget the adverse effects of anticholinergics that you need to be aware of. I've talked to you guys about that already when it comes to anticholinergics. Those adverse effects: can't see, can't spit, can't pee, can't see, that decreased or blurred vision, can't spit, that dry mouth. That's why you offer them sugarless candy or gum. Can't pee, that's the urinary retention that they have. That's the constipation. So you teach them to drink lots of fluids and eat foods with lots of fiber. Yeah, that atropine helps with those secondary symptoms such as the drooling, the sweating, and tremors. Remember, levodopa, which is a dopamine agonist, that's the primary medication you expect to be ordered. Selegiline, that's your MAOI, and your entacapine, that is your COMTI. Select all that applies. Which is contraindicated with the administration of an anticholinergic agent such as atropine? Which would be contraindicated? Glaucoma, urinary obstruction, extreme heat, rapid position changes, nausea, or Professor D, I have no idea, I give up. Now, before you answer, I want you to think about this. When you're thinking about the contraindications for, the administration of anticholinergic agents, remember that poem: can't see, can't spit, can't pee, can't. What do you think contraindications would be? Keeping that in mind. Okay, let's go. I'm happy nobody chose purple. Let's talk about this. Yes, to glaucoma. Can't see. So if an adverse effect is can't see, where you have decreased blurred vision, why in the world would you give this to somebody with glaucoma? You guys know what glaucoma is. That's when that patient has increased intraocular pressure. That makes no sense, right? Can't see, can't spit. Why can't they spit? By the way, you remember how I told you how you're going to give the patient, sugar-free, because you're not trying to make them a diabetic. You're going to offer them sugar-free gum, sugar-free candy. That dry mouth is also known as xerostomia. The reason that they have that dry mouth is that increased dryness that they have, right? So let's go from glaucoma to extreme heat. If they have extreme dryness, they're not going to be sweating. Remember, sweating helps what? Cool you off. Why would you give this to somebody in increased heat where they can't even cool themselves off? Does that make any sense? Absolutely not. Let's go to urinary retention. Can't see, can't spit, can't pee. Can't pee. Why would you give this to somebody with urinary obstruction when we know an adverse effect of that medication is urinary retention? That's why they can't pee, right? And then rapid position changes. Why must they avoid rapid position change? Orthostatic hypotension. Those four, yes, those are contraindicated with anticholinergics such as atropine, but not nausea. Let me tell you something. You see nausea. Nausea is a side effect of almost every single medication on earth, but not a contraindication. There's a big difference between side effect and contraindication. Matter of fact, there's a big difference between side effect and adverse effect. Very often you'll hear those two used interchangeably, but they're not the same thing. So let me talk to you about this right now. Side effect. is something that may possibly happen when the patient takes this medication, and you're going to warn them so they're not surprised. But if it happens, we're not going to take them off the medication. We're just telling them just to warn them. Adverse effect is something that may happen if the patient takes the medication, but under no circumstances do we want it to happen. And we warn them, hey, these are the adverse effects. And if it happens, you have to let us know right away, because we got to notify the healthcare provider. Maybe they're going to take you off this med. Maybe they're going to augment the medication. We don't know. But if any of these happen, you have to let us know. That is the difference between side effect and adverse effect. Let me tell you what contraindication is. Contraindication means under no circumstances should we give this medication if we're seeing, these signs and symptoms, we're seeing these clinical manifestations, we're seeing this scenario. So that's the difference between side effect, adverse effect, and contraindication. How are you guys doing on the live? Can you repeat what you said about extreme heat? Okay, what I said about extreme heat, when it comes to anticholinergics, the patient can't sweat. And the reason that you sweat when you're hot, that sweat helps cool you off, right? So if the patient's in an extreme heat and they can't sweat, what do you think is going to happen? They can collapse. They can have heat exhaustion. So that's why that extreme heat is a contraindication to anticholinergics. Did that clear that up for you? Okay, you're welcome. Last question. Select all that applies. What are important nursing education points regarding the administration of dopamine replacement, such as levodopa? So your patient's got Parkinson's, they got another disorder that you have to give a dopamine replacement, such as levodopa. What are important teaching points? Select all that apply. The drug may take months to achieve the desired effects. Avoid sudden changes in position. Avoid foods high in vitamin B6. Avoid operation of heavy machinery if sedation occurs. Take the apical pulse for a full minute after administration. Discontinue the medication if nausea or vomiting occurs. And there's more than one answer. This is select all that applies. Okay, let's talk about this. So, yes, this drug may take several months to achieve desired effects. That patient's getting levodopa, you have to warn them. You warn the family members. This isn't, number one, this isn't a cure. There's no cure. It's not a cure. It's a treatment, and it may take a couple months before you actually start seeing the desired effects. And the reason you warn them is if you don't tell them that, they're going to think that the medication should work right away. And what happens is they'll stop being compliant and they'll stop taking the medication. Yes, to avoid sudden changes in position. We don't want to be dealing with positional or orthostatic hypotension. Yes, to avoiding foods high in vitamin B6. Why? That vitamin B6 binds the dopamine, and it makes it not effective. So you're going to teach a patient to avoid foods high in vitamin B6, avoid high protein foods such, meats and, liver, those types of foods. Avoid foods high in vitamin B6 because it makes the levodopa not as effective. Avoid operation of heavy machinery. For some people, it makes them drowsy. Do you think it's a good idea for them to be driving while they're drowsy? Absolutely not. So those were correct. What was incorrect was taking the apical pulse for a full minute after administration. No, that's not necessary. And I mean, I know some meds that you take the apical pulse a full minute before administration, which this is not one of them, but I don't know. I can't think of any of after, so that's false. And then discontinue medication if nausea, vomiting occurs. No, nausea and vomiting, those are possible side effects. If it's severe nausea and vomiting, that would be an adverse effect, and we would tell them that, let us know, but we're not going to tell them to discontinue taking the medication. All right, you guys did a great job. Let's see how well you did. Okay, guys, thank you for watching. Please let me know in the comment section what you thought about this video, what other video you'd like to see me do as far as Kahoot, what kind of subjects you'd like to see me cover, or maybe you'd like to see me cover a subject, but not in Kahoot format. Maybe you like it in a lecture where I'm teaching out of the book, or maybe you'd like me to do it question answers, like the type of questions that are released on Sundays at 1 p.m. Eastern Standard Time. Please let me know in the comment section what you'd like to see me cover and how you'd like to see me cover that information. Again, don't forget, you can book your seat right now for a next generation NCLEX review or a one-on-one tutoring session or consultation session by visiting my website, nexusnursinginstitute.com. And while you're there, be sure to check out the audio lessons that I have available. Thank you so much for watching. You guys will catch me on the next video.